Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. This lecture will be very useful to you in your everyday practice as well as in your oral exam and also in your theory, because this is very frequently asked in your theory as well as very frequently in oral, and you will come when you start doing your practice or when you are going for internship. Today we are going to discuss regarding the cranial nerve examination, that is facial nerve examination, or we call 7 cranial nerve. We'll be discussing under this heading anatomy, then different function, different parts of facial nerve, which muscle they supply, what is the function, then how you examine, and interpretation. So facial nerve starts from facial nucleus, which is present in the pons, lower part of the pons. But that facial nucleus is innervated by or controlled by higher center, that is from cerebral cortex, we call pyramidal tract. Now facial nucleus has got two divisions, the upper part and lower part. Upper part of facial nucleus is innervated by both side pyramidal tract, so it is bilaterally innervated, while lower part of the cranial nerve nucleus, facial cranial nerve nucleus, is innervated by opposite side pyramidal tract. This portion from cerebral cortex up to facial nerve is called as upper motor neuron control, or we call supranuclear control. From nucleus, the fiber which supplies the facial muscle, that we call as lower motor neuron or infranuclear. The upper part of the nucleus will innervate two muscles. One we call as a frontalis belli and orbicularis oculi. So these two muscles are innervated by both side pyramidal tract, means it is controlled by both side pyramidal tract. So it is bilaterally innervated, while lower half of the face nucleus is innervated by opposite side pyramidal tract. Hence, it is very easy to understand if you get the damage to cerebral cortex here, or in corona radiata, or in internal capsule, above pons, you will have lower half of the face on opposite side which will be affected, which is innervating the facial muscle below the eyelid, below the lower eyelid. So it will be very peculiar that you will have lower half of the face being paralyzed, sparing two muscles, that is frontalis belli, or also called as occipitofrontalis belli, and orbicularis oculi. These two muscles will be spared, while all the other muscles of half of the face will be affected, and that we call as upper motor neuron palsy. And if you get the damage to nucleus or to the facial nerve, now facial nerve will have two parts, intracranial part, then it has got extracranial part. Whether it is damaged in the nucleus or outside the nucleus, that is outside the pons, both will be lower motor neuron, and that will produce complete half of the face, means frontalis belli, orbicularis oculi, and lower half of the face, complete half of the face will be affected. We call as a lower motor neuron palsy. Now we'll be going further. Now you can see here, this is the facial nerve nucleus. After origin from that facial nerve nucleus, the nerve hooks around what we call a 6th cranial nerve, and while going it is running backward where it produces in the fourth ventricle, little elevation, that is called facial colliculus, and then it runs around the sixth cranial nerve and comes out anteriorly between pons and medulla, and after running that it will run in through, it will enter through internal acoustic meatus in facial canal. We'll be showing you further slide, and then it will emerge out through stylomastoid foramen. Now there will be fibers which will be from the tongue, that is the taste sensation from anterior 2/3 of the tongue, plus touch, pain and temperature sensation from the tongue, which will be running along with the facial nerve, will enter the facial canal, and then it will end into what we call as a nucleus tractus solitarius. So that will be sensory path of facial nerve. So sensation will be supplied to anterior 2/3 of the tongue, that is spatial sensation that we call as a taste sensation, plus the sensation of touch, pain and temperature. That will be going and ending in nucleus tractus solitarius. And the nerve which is passing through this internal acoustic meatus, there will be two nerves. One will be facial and another will be eighth cranial nerve. This will be seventh cranial nerve, facial, which has entered into internal acoustic meatus. It runs anteriorly, and this is the eighth cranial nerve. And at the end of this facial canal, it will bend, and that is called geniculate nucleus. And then it runs posteriorly and laterally, and it will come out through stylomastoid foramen. It will come out through stylomastoid foramen. There will be one fiber which will be going, and it will supply this particular fiber. It will supply. You can see this. Lacrimal gland. Now in the middle ear, it will be running posteriorly, and then it will be coming down and comes out through stylomastoid foramen. So you can see here, this is geniculate ganglia, this is running posteriorly, and after coming out it will give one branch, that is posterior auricular branch, which will be giving a somatic nerve supply sensation just behind the ear pinna. Then it will be giving to nerve 2, posterior belly of digastric. One branch will be given to nerve 2, stylohyoid muscle, and then it will be running in parotid gland. Now in parotid gland it will form ansa lenticularis, and then there will be a branch, temporal branch, zygomatic branch, buccal branch, mandibular branch and cervical branch, and accordingly it will be supplying different groups of muscles. That will be showing you further. As well as there will be one branch we call as a chorda tympani branch, which will be coming out through pterygoid tympanic fissure, and then it will be combining with the fifth cranial nerve, lingual branch. This will be a lingual branch of the fifth cranial nerve, and then it will be supplying sublingual salivary gland and submandibular salivary gland. So it will be supplying those two glands and anterior 2/3 of the tongue, taste sensation. So this will be the two salivary nucleus and anterior 2/3 of the tongue, taste sensation will be supplied by chorda tympani branch, which is a branch of 7 cranial nerve, and those fiber will end in nucleus of tractus solitarius. So sensation will end in that nucleus tractus solitarius, and that taste sensation will then go and end in a cerebral cortex of temporal lobe. So if we go through a summary of entire thing, that it arises from pons, there will be two group of fiber, motor and sensory. It will enter through internal acoustic meatus, which is a part of a temporal bone. Then it will run in a facial canal. It will bend at the genu, we call geniculate ganglia. There it will give rise to one nerve that is called greater petrosal nerve. Then nerve to stapedius muscle, which is pure motor. This petrosal nerve is a parasympathetic to one gland, that is we call lacrimal gland. Chorda tympani branch, which will be a taste sensation to anterior 2/3 of the tongue. Then it comes out through facial canal via stylomastoid foramen, which is an extracranial division. So this is an intracranial division. So in intracranial division, it gives out these three branches: greater petrosal nerve, nerve to stapedius, and chorda tympani branch. This nerve to stapedius will take part in movement of stapes bone, and which will be helping in acuity of hearing. After coming out from stylomastoid foramen, posterior auricular nerve will supply the skin part behind the ear pinna. Then it will supply two muscles, that is posterior belly of digastric and stylohyoid, which helps in elevating the floor of the mouth, and that will take part in deglutition. And then it gives out the 5 branches: temporal, zygomatic, buccal, marginal, mandibular, and cervical. So now this will summarize everything. So facial nerve will have a 4 component, that is brachiomotor, parasympathetic, sensory, spatial sensory, that is taste sensation. This will be the 4 groups of function. Brachiomotor in the petrosal part enters in the internal auditory meatus, and from the geniculate ganglia now you are getting 3 branches. One we call as a superficial petrosal, which will be supplying the lacrimal gland, as well as it will be supplying sphenoidal sinus, frontal sinus, maxillary sinus, ethmoidal sinus, nasal cavity. This will be greater petrosal nerve. And then there will be one sensory fiber, sensory, that will be via chorda tympani, that is taste sensation, to anterior 2/3 of the tongue via chorda tympani, which will be combining with lingual branch of a 5th cranial nerve, that is mandibular division of the 5th cranial nerve. And in mandibular division there is a lingual branch, it will be combining with that, and with that it will be supplying anterior 2/3 of the tongue. This will be the spatial taste sensation, and it will be also giving rise to small contribution to the external acoustic meatus, small contribution to. And there will be one branch to stapedius muscle, one branch to stapedius muscle, and that will take part in movement of the stapes bone and acuity of hearing. After coming out through the stylomastoid foramen, there will be posterior auricular branch, which will be supplying the skin part behind the ear pinna. Then posterior belly of digastric and stylohyoid muscle, which will be taking part in deglutition. Once it enters the parotid gland, after coming out from stylomastoid foramen, it enters the parotid gland, where it will form ansa lenticularis, and from there you will get 5 branches. Temporal branch will supply frontalis belli and orbicularis oculi. Zygomatic branch will supply the muscles around the eye and around the orbit. as well as elevators, we call muscle which takes part in smiling. Buccal branch will supply buccinator and upper part of the lip, that is movement of the upper lip. Mandibular division, or we call marginal mandibular branch, will supply orbicularis oris and lower lip, which will take part in movement of lower lip and depression. And cervical division will supply platysma muscle. So this will be the different group of muscle which will be supplied, and will be in few slides will be mentioning the action of each. So this is a supranuclear portion, this is a nuclear portion, and then this is an infranuclear portion. In infranuclear portion, we have got the portion from the pons to internal acoustic meatus. So in this particular portion, you can have a pathology which can produce a damage to the facial nerve. It will be a lower motor neuron. If there is any damage at the level of the nucleus, that is in the pons, it will be again lower motor neuron. In this facial canal, we'll have a branch which will be greater superficial petrosal, which will be supplying lacrimal gland. Then we will have two stapedius muscle, and we will have chorda tympani, which will be supplying anterior 2/3 of the tongue, as well as there will be fiber which will be going to submandibular and sublingual gland, which will be taking part in salivation and taste sensation of anterior 2/3 of the tongue. And then when it comes out to stylomastoid foramen, it will be supplying the muscles of the face, as well as it will be supplying digastric belly, posterior belly of digastric muscle, and stylohyoid, which will be taking part in deglutition. Same thing is mentioned here. So I'm skipping this particular slide. So this is from brainstem, enters the internal acoustic meatus, greater petrosal nerve, supplying lacrimal gland. Then you have got branch to stapedius muscle concerned with acuity of hearing, stylomastoid. Before coming out, then there will be one branch which will be chorda tympani, which will be supplying anterior 2/3 of the tongue, and along with that the fiber will also run and supply submandibular and sublingual salivary gland. Posterior auricular branch and two other branch, that is to digastric belly and stylohyoid muscle, and it will be supplying temporal, zygomatic, buccal, mandibular and cervical to the facial muscles. This is in detail how exactly you get that supply. This is muscles of expression, and platysma is just a vestigial muscle. It takes little part in depression of the mandible or opening of the oral cavity. While this chorda tympani branch will be supplying anterior 2/3 of the tongue, as well as sublingual and submandibular salivary gland. Already we have mentioned, and almost we have covered up everything. So this will be the 5 branches: temporal, zygomatic, buccal, mandibular and cervical. So while evaluating, you have to ask the person different action. So while doing a motor function, we'll be asking some person to do some action. So we ask the person to show the teeth, close the eye tightly. Now you can see here, the person is not able to close this eye, and there is no contraction of the muscle on this side. That is we call as right side of the patient. There is a drooping of the angle of the mouth. Nasolabial fold is not seen and unable to close the eye. You can see here the furrowing. This eyebrow is lifted up. There is no elevation here. So frontalis belly is not working, orbicularis oculi is not working, and these facial muscles of expression, etc. are not working. This means complete half of the face is being paralyzed. So this will be classical lower motor neuron. This will be because the damage to the same side, facial nerve nucleus in pons or facial nerve outside the pons, intracranial division or in the canal or outside the canal. Anywhere if you get the damage, you will have lower motor neuron palsy on same side. While here if you see, person is able to close the eye, there is little amount of eyebrow elevation, but the nasolabial fold is not clear and the angle of the mouth is drooping down. This is lower half of the face is being paralyzed. This is innervated by opposite side cerebral cortex. So it will be a damage to pyramidal tract or corona radiata or at internal capsule above the midbrain or in the midbrain of opposite side. So it will be upper motor neuron palsy in this particular patient on left side. So you've got a right side upper motor neuron lesion. So that I've already explained before. Now you will ask the person to close the eye tightly. So when he is trying to close the eye tightly, you will see the eyebrows are lifted up. You will see furrowing. You will have a closure of the eyelids and you will have a nasolabial fold becoming a prominent. So if there is any change in that, you will be able to make out whether it is upper motor neuron or lower motor neuron. You ask the person to blow the cheek and you can find out by applying a resistance on the two sides. You can do the test sensation on anterior 2/3 of the tongue. We'll be doing separately. You can also go for the hearing test for stapes muscle. So these are all the different muscles. Temporal branch will be supplying frontalis belli and orbicularis oculi. Zygomatic branch will also supply zygomatic major, minor, levator labialis superioris, levator labiali superioris aliquinesi, and also it will be innervating orbicularis oculi. Buccinator will be innervating orbicularis oris and buccinator, while marginal mandibular branch will be supplying the depressor part and lower lip muscles, and cervical branch will be innervating platysma muscle. So stapedius muscle is supplied by nerve to stapedius. Posterior belly digastric and stylohyoid by nerve to posterior belly of digastric and nerve to stylohyoid. Temporal branch will be supplying frontalis belli and occipital orbicularis oculi. Zygomatic branch will be supplying orbicularis oculi. Buccal branch will be supplying buccinator, orbicularis oris, nasalis branch, levator labialis superiorris aliquinesi, zygomatic major, zygomatic minor, levator angularis oris, etc. And mandibular division orbicularis oris, which is also supplied by buccal branch as well as mandibular branch. Then depressor muscles, etc. Cervical platysma and posterior auricular branch will be occipitalis muscle. In some, it is prominent, so person can move a little part of the posterior movement may be seen. Frontalis belli helps in raising the eyebrow, and while raising the eyebrow you get furrowing of the forehead. Orbicularis oculi is for tight closure of the eyelids. So while closing the eyelids tightly, the eyebrows are moved down. In orbicularis oris, approximation of lips and closure of the oral cavity. Zygomatic branch protrudes the upper lip, puckering. It takes part in puckering. Levator angularis oris lifts up the upper border of the lip, upper lip. Zygomatic branch raises the lateral angle of the lips, that is for smiling. Buccinator for blowing. Mentalis muscle raises and protrudes the lower lip. Temporalis masseter close the jaw tightly, that is temporalis and masseter, that is innervated by fifth, while pterygoid will take part in movement of the jaw, while this will be the muscle which will be taking part in expression. This will be all the muscle which will be taking part in expression. These are all facial, innervated by facial up to buccinator. So frontalis belli will have a wrinkling on the forehead. Orbicularis oculi will be closer of the eye. Orbicularis oris will be helping in whistling. Buccinator in puffing of the mouth, or we call blowing. Dilator muscle of the mouth will be showing the teeth, and platysma will forcibly pull the angle of the mouth downwards and backwards, as well as it will help in little depression of the mandible. So while testing for that facial nerve, we test the muscle action. We look at the anterior 2/3 of the tongue, taste sensation. Very rarely we do the sensation from external ear. For stapes bone or stapes muscle, you can do the hearing test by audiometry. And for secretomotor function of lacrimal gland, that will be one test for lacrimal gland, and you can do also for salivary gland. So first part of method of testing is look at the nasolabial fold, whether it is seen clearly and bilaterally equal or not. Whenever a person is just talking to you, you can easily observe for that. Or when the person is just keeping his face steady. In upper motor neuron, you will have furrowing of the face present, and lower half of the face nasolabial fold will be absent. While in case of a lower motor neuron, the side on which there is a damage, the nasolabial fold will be absent, furrowing will be absent, and person will not be able to close the eyelid. The eye will remain open. The person will not be able to close the eye. So look at the furrowing of the forehead. If it is present, it is normal. If it is absent, it is more classical in case of a lower motor neuron on the same side. Blinking will be absent again because person is not able to close, because orbicularis oculi muscle is not working. So person will not be able to blink. So that will be again very common in lower motor neuron palsy. As far as expression is concerned, while talking, while smiling, in case of Parkinsonism, it is expressionless face, or we call mask-like face. Also, it will be affected in case of person who is having a psychological disorders like depression, in schizophrenia. Also, expression is usually absent. The person who has got a lower motor neuron palsy, there will be dribbling of saliva from the angle of the mouth. Angle will be drooping down. In some of the person, you might have frequent spasm of facial muscle, we call facial tics, facial spasm and twitching. And very rarely you see crocodile tears, that is while smiling there is a tear coming out from the eye because of abnormal innervation after the facial nerve injury, that is called crocodile tears. So while testing for the motor action, you ask the person to elevate the eyebrow, close the eye tightly, clenching of the teeth, smiling, whistling or blowing of buccinator, and swallowing. So while you are furrowing, you are testing frontalis belli. When you are asking the person to close the eye, you are testing orbicularis oculi. And in a person in whom you have got a lower motor neuron palsy, while person is trying to close the eye forcibly, you will see the eyeball is rolling up. That we call as a Bell's phenomena. When he is clenching the teeth tightly, you are asking the person to use the masseter and temporalis belli, but simultaneously there is also elevation of the elevators of facial muscle. And while smiling, you are asking the person to use the elevator muscles plus the upper lip muscles. Whistling is done, or whistling or blowing is done by buccinator, and swallowing will be done by orbicularis oris, closing of the orbicularis oris, and then buccinator with the other muscle which takes part in elevation of the floor of the mouth, including even tongue. So this will be the different action you can test while doing examination of the facial nerve. Here you can see you are asking the person to elevate the eyebrow, means we are testing for frontalis belli. You are asking the person to close the eye tightly, you are testing orbicularis oculi. So this is frontalis belli, this is orbicularis oculi. And when the person is asked to frown the side of glabella, you will see this vertical folds. Then when you ask the person to blow the cheek and you can find the resistance, that is for buccinator muscle. You are asking the person to show the teeth, and while that you are testing for the levator muscle, levator labia muscles, this levator muscles. And when you are asking the person to close the lip tightly, that is orbicularis oris. And when you are asking the person to clench the teeth tightly and the platysma muscle will be making tight, that will depress the mouth and pulls it backward. That will be platysma muscle. So show the teeth, open his mouth, look at the nasolabial fold, close his eyes, frown. You look at the wrinkle of the forehead. You ask the person to raise the eyebrow. Then ask the person to show the teeth and open his mouth, blowing of the cheeks. Ask the person to purse the lip, etc. are the different movements. Here you are asking the person to elevate the eyebrow. Here you are asking the person to frown. Here you are asking to blow the cheek. Here you are asking to purse the lip, smiling, and you are asking the person to close the eye tightly. These are all the different actions you will be asking, and you will be looking for whether the muscle is working or not. So this will be the motor system examination of facial nerve. Here you are asking the person to close the eye tightly and you are trying to pull it up, open the eyelids. Here you are asking to elevate the eyebrow. So this is furrowing of the eyebrow, uplifting of the eyebrow, and you can see the furrowing of the forehead. Here you are asking to blow the cheek and you are looking for the resistance during that blowing of the cheeks. This is elevation. You are looking at the furrowing. This is closure of the eyelid. This is wrinkling of the forehead. This is the closure of the eye tightly. Here you can see that this side eye cannot close. There is no elevation of the eyebrow. So frontalis belli and orbicularis oculi are affected. Plus, while closing the eye tightly, you can see the nasolabial fold here very clearly. This angle is lifted up, but this angle is not lifted. There is no nasolabial fold seen clearly. So complete half of the face is being involved. So this will be lower motor neuron palsy on left side. So inability to smile, inability to close eye or raise the eyebrow, whistling is impossible, drooping of the corner of the angle of the mouth, and while closing, the eyeball rolls up, that we call the Bell's phenomena or Bell's phenomena or Bell's sign, and inability to wrinkle the forehead, that is typical of lower motor neuron palsy. So loss of blinking of the eye, slurred speech, mask-like face appearance, loss of taste sensation and salivation also, and pain around the back of the ear. This will be in classical in case of a lower motor neuron palsy. So you can test for anterior 2/3 of the tongue, taste sensation, and that will be done. You will have to explain the person regarding the test. We have already discussed that in a fifth cranial nerve. So you will be testing with sweet, salt and sour sensation. Mainly we use the common solutions which are very familiar to the person like tea, coffee, peppermint oil, sorry, not peppermint oil, we call rose water, sugar, salt, etc. So those particular common solutions are being utilized. Lemon, you can utilize those common sensation. We should not utilize the strong sensation. Strong sensation should not be utilized. So don't use say asafoetida or say bitter sensations because they will remain for a longer period. As far as superficial petrosal nerve is concerned, you can look for the lacrimal secretions and salivary gland, particularly submandibular and sublingual salivary gland. Usually that is not commonly being done. So secretomotor function for lacrimal gland, there is one test named as Screamer's test where you expose the person to orange skin or onion or ammonia and look for the lacrimation. It will be affected in lower motor neuron palsy. Salivary secretions while chewing the food, you can look for the salivary secretions and you can look for the anterior two-thirds of the tongue taste sensation. The nerve supply to the stapedius muscle, you will be able to identify by examining in audiometry. And simultaneously, because motor pathway is orbicularis oculi, that is seventh cranial nerve, you will look for corneal and conjunctival reflexes because fifth cranial nerve will be sensory pathway, center will be pons, and motor pathway is seventh cranial nerve supplying orbicularis oculi, and that will be corneal and conjunctival reflexes, which we have already discussed in detail in fifth cranial nerve. So corneal and conjunctival reflex, sensory pathway fifth, motor pathway is seventh. So afferent fifth and seventh. This will be fifth. Sorry, this is fifth. Afferent limb will be fifth. Yes. So fifth division 1, that is we call as orbital division, or we call ophthalmic division, which will be supplying cornea and conjunctiva. And efferent pathway will be seventh cranial nerve. So this is conjunctival reflex, this is corneal reflex. So whenever you get the damage to cerebral cortex or pyramidal tract in corona radiata or in internal capsule up to pons, that is where it ends in a nucleus. So this particular portion will be supplying in the nucleus. In nucleus there are two divisions, upper part and lower part. Upper part is bilateral innervated, lower half of the face which is supplied by lower part of the nucleus, which will be innervated by opposite side pyramidal tract. And again, after coming out from the pons, it has got a infranuclear portion that is inside the facial canal and outside the facial canal. In the facial canal, it gives out three branches. One, superficial petrosal nerve, which will be supplying lacrimal gland. Then we have got now to stapedius, and then cauda tympani branch, which will be supplying anterior two-thirds of the tongue and secretomotor fibers to salivary gland, that is submandibular and sublingual salivary gland. And the nerve which is outside the facial canal, which will be giving one branch, that is posterior auricular branch to occipitalis muscle, as well as partly innervating the skin part of it. Then it will be supplying posterior belly of digastric and stylohyoid muscle, which will be taking part in deglutition. And then it will give out temporal branch, zygomatic branch, buccinator branch, mandibular branch, and cervical branch. and that will be supplying entire half of the face, that is muscle of facial expression, the muscle which takes part in elevation of eyebrow, furrowing of the forehead, closure of the eyelid, as well as platysma muscle. So this will be supranuclear division, and this will be nuclear and infranuclear division. We have already discussed in detail everything. You can see here there is a closure of the eyelid, there is a nice nasolabial fold, there is a lifting of the angle of the mouth. Here there is no lift of the angle of the mouth, no nasolabial fold, no closure of the eyelid, no movement of the eyebrow, no furrowing. So this side lower motor neuron palsy, means we say that left side lower motor neuron palsy. So whenever you want to examine for the facial nerve, always take a history of traumatic and non-traumatic. We are not dealing with the traumatic part, so I am skipping that part. In a traumatic part, it will be mainly due to the fracture of extracranial damage, trauma, or temporal bone fracture. This will be the two major portion which will be producing damage to the facial nerve. Now, in a non-traumatic part, you will have to differentiate between the two. We call as a supranuclear division. In a supranuclear division, it is very commonly because of the cerebrovascular damage, and that will be due to middle cerebral artery, damage to parietal lobe area, frontal lobe area, which is a motor area, or to the corona radiata or internal capsule. Again, in internal capsule, mainly it is supplied by the branch of the middle cerebral artery, and then it may be damaged, pyramidal tract may be damaged in the midbrain and in upper part of the pons, because facial nucleus is present in the lower part of the pons. While then as we come to the periphery, it will be at the level of pons, that is lower motor neuron palsy, in the nucleus, or after the facial nerve comes out of the pons, that is we call as outside the pons, intracranial pathway and extracranial pathway. In an intracranial pathway, it is inside the facial canal, and extracranial pathway is outside the facial canal. So whenever it is outside the facial canal, it will produce damage to motor function sparing chorda tympani, stapedius muscle, and lacrimal gland. So this will be spared. And if there is a damage inside the facial canal, all those function including extracranial portion will be also damaged. So you will have to approach accordingly. This is Shimmer test, where you are testing for lacrimal functions. So you will have to keep a filter paper here over the lower eyelid and look for the lacrimation is present or not. You can see here this paper. This is called Shimmer test. Screamer. So you will be looking for that. Very rarely we require. This is now to Stapedius reflex test done by a special instruments. So absence of the reflex will indicate the damage to now to Stapedius muscle. So that will be done by a special type of instruments, will be done by ENT person. And you can go for what we call as anterior 2/3 of the tongue taste sensation, and that will be also affected in a person in an intracranial pathway. There is also a test called Electro Gestometric, which will be helping to identify that taste sensation is damaged or not. Then this is to find out the salivary flow test, will require a special technology. Now there is a difference between upper motor neuron and lower motor neuron, I have already mentioned. So in an upper motor neuron, it is a lesion above the pons, while this is below the pons, in the pons or outside the pons. Patient can furrow and patient can close the eye very clearly. Lower part of the face is only involved, while here the entire whole face is involved. This will be very frequently along with hemiplegia because of the damage to the pyramidal tract. You will also have the upper limb and lower limb involved on the same side of the facial nerve damage. Means we call same side of the hemiplegia, you will have a lower half of the face being involved. While in a lower motor neuron, it will be only complete half of the face. But when it is associated with hemiplegia, it is usually contralateral hemiplegia. It may be associated with hemiplegia, but it is usually on the side of the damage, lower motor neuron, and opposite side, you will have hemiplegia. So that will be the difference in upper motor neuron. At your leisure time, you can go through. This is in detail difference between the two. You can have a pause. If you have got upper motor neuron palsy on one side, which is very classical in stroke, once in a while you come across in multiple sclerosis or maybe because of tumor, etc. Bilateral upper motor neuron will be very common in case of what we call as a pseudobulbar palsy. Bilateral lower motor neuron is seen very frequently in GBS, once in a while in diabetes mellitus, bilateral Bell's palsy. This will be the two common conditions: GBS, diabetes mellitus, and bilateral Bell's palsy. While unilateral will be very frequently seen in a Bell's palsy, may be seen in a chronic otitis media, post-traumatic, parotid surgery, Ramsey syndrome, or if there is a damage because of CP angle tumor, particularly we call 8th cranial nerve meningiomas, or maybe because of a brain stroke, particularly damage in Millard Gubler. This will be the common condition where you can get lower motor neuron. If we cannot identify the cause of lower motor neuron type of palsy, then only we label that as a Bell's palsy. All this condition where we can identify the etiology, we label that as lower motor neuron palsy, not as Bell's palsy. In case of myoneural junction disorders, particularly myasthenia gravis, and in case of a facioscapulohumeral muscular dystrophy, that is a myopathy syndromes, this will be bilateral involvement of facial muscles. This will be facial muscles. There is no damage to facial nerve. It is a muscle and myoneural junction disorder. This is a disorder of muscle. This is a disorder of myoneural junction. So as far as nerve is concerned, GBS, diabetes mellitus, and bilateral Bell's palsy. Very rare to get a bilateral Bell's palsy. So among congenital, we call as myotonic dystrophy. Among neurological, Guillain-Barré will be very common. Multiple sclerosis, stroke, myasthenia gravis will be myoneural junction disorders. Among endocrine, diabetes mellitus. Among tumor, parotid gland tumor will be very common. Systemic disorder, sarcoidosis and amyloidosis can produce. Among infection, otitis media, Ramsey very common. Also in case of necrotizing otitis externa can also produce a damage, Lyme's disease, etc. These are all. And traumatic injury in a temporal bone fractures or birth trauma can produce facial palsy depending upon where the damage is. So there are a lot of conditions which can produce the damage: trauma, hypertension, eclampsia, Lyme, sarcoidosis, diabetes mellitus, Ramsey Sjogren syndrome, amyloidosis, then parotid gland tumors, GBS, 8th cranial nerve neurofibroma, multiple sclerosis, motor neuron disease, etc. All these disorders can produce. In a hemiplegia, you test for the face, arm, speech and time. So you will have a lower half of the face gone. You can see here, there is no nasolabial fold. Lower angle of the mouth is drooping down. So you have got lower half of the face involved. There is a furrowing present, means the frontalis belli is working nicely. So you have got a upper motor neuron palsy on this side. So damage has to be on opposite side pyramidal tract or opposite side cerebral cortex. So either in the pyramidal tract, this is corona radiata, this is internal capsule, anywhere here or in corona radiata or internal capsule or in this fiber before pons, before pons. So you will have a lower half of the face as well as same side hemiplegia. So you will have a hemiplegia and facial lower half of the face same side in case of upper motor neuron. And here you can see when you get a lower motor neuron, the angle is drooping down, there is no furrowing. This will be classical lower motor neuron. So paralysis of ipsilateral upper and lower facial musculature, entire half of the face, that you will call classical lower motor neuron. While in upper motor neuron, when you get in an upper motor neuron, say you have got a damage here, the lower half of the face is affected. The eyebrow you can see at same level. Here person is unable to elevate the eyebrow. So that will be very peculiar. We have repeated many times. So together here now you can see there is no uplifting. The angle of the mouth is at the same level. Same level. You can see here. So paralysis of ipsilateral upper and lower facial musculature. This will be lower motor neuron and this will be upper motor neuron. This will be upper. Lower half of the face if it is involved, it is upper motor neuron. Now here you can see complete half of the face gone. Drooping of the no furrowing. So this side lower motor neuron. Here furrowing present, only drooping, no nasolabial fold. Lower half of the face gone, upper motor neuron palsy. Again you can see here, no furrowing, nasolabial fold absent. This angle is lifted, this angle is not lifted. So there is a smooth forehead, inability to close eye, drooping of the nose. This nose is drooping. Corner of the angle of the mouth is also drooping, and there is no nasolabial fold. So this side lower motor neuron facial palsy. Again you can see complete half of the face gone. So lower motor neuron palsy. Here furrowing present, furrowing absent, inability to close. Nasolabial fold is nearly absent. Angle of the mouth is drooping. Even this nose is drooping. Lower motor neuron. Here furrowing is present. No nasolabial fold. Angle is drooping. Upper motor neuron. Bell's phenomena. Typical. You can see Bell's phenomena. Classical. Here when the person is trying to close, he is not able to close the eyelid. Nasolabial fold is not seen. And while closing tightly, person is not able to close and you will see the eyeball is rolling up. This is classical Bell's phenomena. Again you can see here, eyeball is rolled up and person is trying to close. Typical Bell's phenomena. Again you can see eyeball is rolled up, no nasolabial fold, angle is drooping down, even this nose is drooping, and this is classical Bell's phenomena, no furrowing. This is lower motor neuron on right side. Special situations. Bilateral. You can see that typical. No nasolabial fold. No furrowing. Again, you can see that both sides almost you can't see clearly. Now if you ask the person to close the eye, now you can see that both eye unable to close and both side you can see Bell's phenomena. Now patient is asked to smile. Here you can see angle is lifted up. Eyebrow is also up. Here eyebrow is not moving. Angle is down. So this will be this side. Lower motor neuron. Here again same. Here you can see the angle is not lifted up, means, but this is at the same level. So upper part is working, lower part is, this is upper motor neuron. Now here you can see this will be upper motor neuron here. This will be lower motor neuron. Here you can see while closing the eye, eyeball will roll up. Here while opening the eye, this side furrowing is almost absent. Nasolabial fold is also not seen. Angle is drooping down. You can see angle is drooping down. No nasolabial fold. And sometime you can get half of the face atrophy also. That is in facial hemiatrophy. This is, you can see the crust. This is secondary due to herpes. So this will be typical, and he has developed a lower motor neuron, facial. This is Ramsey Hunt syndrome. Almost we have covered up everything. So these are some of the signs. If you are interested, whenever you are free, you can go through. Very rarely asked in your oral exam. So I end my lecture here. So I feel this lecture will be helpful to you in your oral exam as well as theory exam, and whenever you go for your private practice. You should be able to differentiate upper motor neuron and lower motor neuron, because identification is very important. Now if you find this lecture is helpful to you, don't forget to press button like, subscribe, and you can share with your friends. At the end of this lecture, I thank you all for taking out time. I know that your time is valuable, and I appreciate you spend some of the time with me. See you in next lecture.